A very warm welcome to the first episode of the Philips African Dialogues. As it's Women's Day and indeed Women's Month here in South Africa, we'll be focusing on discussing Millennium Development Goals 4 and 5. And what they aim to do is reduce child mortality and also increase and improve maternal health care on the continent and other emerging economies. And joining us for this discussion are our experts. And here we have Sikonjiwe Masilela, who's Director for Maternal Child Health and Nutrition from the Gauteng Province Department of Health. We've got Dr. Dumisani Bomela, who's the CEO for Hospital Association of South Africa. And we have David Russell, who's the President and General Manager for Mother and Child Care Business for Philips Healthcare. We have Professor Alex van den Heever, who's Old Mutual Chair of Social Security. And right here next to me is Professor Helen Rees, who's Founder and Executive Director of the WITS Reproductive Health and HIV Institute. Thank you so much for joining us for this discussion. And I'm going to start right there with Mr. Sikonjiwe Masilela. We have all these stats on what's happening on the African continent, what's happening in South Africa, where we are when it comes to reaching the Millennium Development Goals. In your opinion and all the information that you're receiving in your office, where are we?
We are moving, but very slow. Moving very slow in the sense that if you look at currently the Gauteng chapter on the report that has come out now, the triennial report 2008-2010, we are at 150 from 167. We are moving. The maternal death now it's at 150 per 100,000 live births from 167 per 100,000 live births. And when you look at, I think the major challenge will be still the child improving, trying to reduce the child mortality rate. If we look at the statistics of 1990, we're at 45, and we are moving a little bit going up. But the major challenge is that we've got all these plans that we put, but the follow-up seems to be the major. If you look at the current report is talking about almost the recommendations are similar from all the reports. We see that our challenge is the health care professionals. We still have a challenge with skills, knowledge, following of protocols. We have a problem with our systems. The health systems still is a challenge, the health systems. We have a problem with communities. Now, one of our indicators that we would like women to come to antenatal care at 12 weeks with the new protocol. So that is still the challenge that we seem to be having.
Professor Rees, I'd like to bring you into this discussion. One of the things that he was talking about is infant mortality, and that's one of the MDGs that we're trying to discuss today. But one of the things that I had asked you even before this discussion was we have the issue of HIV and AIDS on the continent, and we also have the issue of immunizations. And one of the things you say to me is that it seems as though, yes, we are doing the work, but it doesn't seem to be enough. What seems to be the bigger cause here in South Africa? Is it the issue of HIV and AIDS, or is it the issue of that immunizations and the system not working as it should?
Well, I think I'm going to differ a little bit in terms of where we are as a country. I think the health minister has made it very clear that both for maternal mortality and infant mortality, that instead of seeing a progressive decrease, which is what we should have seen over the last few years as a country, what had happened when he took office is, in fact, we'd seen a reversal of gains. So we'd actually seen maternal mortality increasing, and we'd seen infant mortality and under 5 mortality increasing. And the primary driver in South Africa for both those things has been HIV. And so if we are going to tackle maternal mortality seriously and infant mortality, we had to tackle the HIV epidemic, and particularly in this case around women and around the whole pregnancy time when there's transmission of HIV to infants. So in terms of mother-to-child transmission, we've done very well as a country. When we started, before we had antiretrovirals, transmission rates were very high. There was probably about 30%. With the introduction of the first sort of regimen of antiretrovirals, we were able to reduce them to 15%, and now we're seeing reductions to the latest figures, under 3% transmission from an infected mother to her infant. And that's life-saving, because many of these infants, as children, won't live beyond 2 years. And if those who live longer, often the quality of life is impaired because of having to be on antiretrovirals.
Dr. Pamela, I want to bring it to you. Where do we start? Because on the one hand, we do have government and other sectors that have said it is about the system, and the system perhaps not working as it should. And then on the other hand, you have so many other issues that are feeding into that. Where do we start? Because just hearing the two comments that we've had so far, it seems to be such a broad problem of where do you actually start working at this?
The primary custodian of healthcare is government. They are enabled by law and the Constitution. And in doing so, government may utilize all resources that are available within the South African healthcare sector, and is at liberty to do so. So from a private sector standpoint, we are ready to offer that supportive role to government. Historically, there hasn't been a good history of working together and seeing each other as part of the same team, a team we could call Team Healthcare South Africa. And therefore, I think that is the primary challenge, overcoming those historical prejudices and attitudes that have prevented us from coming together and working together. And I'm sure during the discussion in this session, we'll be able to explore some of the practical ways in which that support can be provided.
Do you see it getting any better, though, in the discussions that you've probably had with government so far?
At this point, we feel that there's so much potential and so much to be done to try and get the private sector and the public sector to work together. We still fractured along the private-public line as a health sector in South Africa. And we are all keen as players within this sector to leverage and complement each other and leverage the skills that are available on both sides of this divide.
Director Masilela, I have to ask you though, when it comes to that seeming not to work together, or there seems to be a problem, there seems to be historical mistrust, from your side as government, what do you think is really happening?
I think what is clear, if you are looking at the burden that is carried by government, I mean, we're servicing almost 95% of the population, and the funding. Now, when you talk about people working together, remember we've got the private sector, healthcare focusing on profits. They're looking at profit margins, and then this other side, we're looking at providing this comprehensive healthcare to this unemployed people. There's still inequity in the health system, and once you still have that inequity in the expenditure, we are still going to see these problems going on for quite some time.
Professor van der Heever, I can see you shaking your head there.
Yeah, I think the way that is raised is a bit of a cop-out. The public health system in South Africa is extremely well funded in comparison to many other developing countries, but its performance is considerably below that of many other developing countries. So that's the first question that has to be examined in terms of performance, including maternal mortality ratios, and which can't entirely be blamed on HIV and AIDS. And that in itself is also a cop-out. There are serious problems in healthcare delivery in South Africa in the public sector, and the causes of that are not actually being addressed. The private sector and the division between the public and private sectors are largely a consequence of the structural designs that government has failed to implement. So those intersections between public and private sector do rely fundamentally on government to be able to come up with a logical way of harmonizing the two sectors. And no coherent plan to date has ever been put on the table that actually attempts to achieve that harmonization. So we are not accessing some of the goods and services in the private sector. I think another issue to raise is to talk about differential expenditure between the public and private sector on a per capita basis is also got nothing to do with the core problem. If you look at the resource differentials between the public and private sector, in the case of general practitioners per population, they're actually very close between the public and private sector, as are registered nurses, for instance. So you can't explain the performance differences between the sectors on the basis of resource differentials.
I don't think I agree with the professor there, because if you look at doctors, out of 10, only 2 are working in the public sector. So you can't talk about resources. You look at nurses, only 4 out of 10 are working in the public sector. So when you start breaking that down, then you find out that there are provinces who don't have specialties. You see, when we talk to the whole country, again, when we talk to child mortality or under 5 mortality, we are talking to your maternal mortality. The issue is that inequity, not only in skills, also inequity in the even in funding. I hear people talk about funding as if it's equal. If you look at Gauteng, for example, we're not only looking at the Gauteng province, we're looking at the rest of the country, and some people who come from outside the country, from the continent, who are not budgeted for, and that we're not doing anything that is coherent between private and, I mean, there's national health insurance that the minister is talking to, which is vehemently opposed by some quarters. We need to look at that.
David, I'd like to bring you here from a global perspective. You go all over the world. Philips is operating in so many emerging countries all over the world, and you have a very good sense of what's happening, even BRICS. And I bring up the BRICS because South Africa being a part of that. And even in that block, South Africa is doing much worse than Brazil, much worse than Russia, much worse than China. And even when it comes to India, you know, we're not doing as well as those emerging countries are doing. When you hear this debate and when you see what's happening in other countries, what do you think a solution could possibly be?
You know, I would say from the industry perspective, we really are not in the depths of the politics of the healthcare systems, but what we are trying to do is to see the similarities between the requirements in the various countries that we're addressing, who are in, let's say, similar situations of not having the statistics in terms of perinatal mortality rates or maternal morbidity and mortality rates. And what we find, I believe, in general, is that the basic requirements are somewhat similar, that the solutions that we bring to the table, and I would emphasize the word solutions, because it's not about a product at the end of the day, what we're trying to do. It's from the education, how to use the equipment, the intuitiveness and ease of use of that equipment. We heard the comment about you know, the resources and the capabilities of the healthcare professionals. Bearing that in mind, you know, we try to develop solutions that are intuitive and easy to use, that can actually make a difference, that have contributions in terms of interpreting data in a sensible manner. And more importantly, and that's the essence of what we're trying to do in the Cairo to Cape Town Roadshow, is you'll see the emphasis is actually less on the equipment that we provide and more on the education and training around that equipment. Because in your examples, if you go to India, for example, or to Russia, you'll often see quite reasonable equipment that could make a difference. Incubators, warmers, monitoring equipment that is sitting there because they don't know how to utilize it properly or don't have the accessories and the supplies required to effectively use the equipment. And it's quite sad to see children living there who could be using the equipment and it's just sitting there in the closet or broke down and was never repaired. So we're looking at it from training, education, equipment that's easy and intuitive to use, that's comprehensive in the sense of that we look across all of mother and child care, from early pregnancy through to the newborn and also the sick infant in neonatal intensive care, but also again the training, the education, also the support of the equipment after it's purchased, that it works stably and reliably for many, many years. I think that is, from industry, what our contribution is and should be to the solution.
David, what I want to ask you is, one of the things I was discussing to you before we started talking was the Ghana example, and that's part of your roadshow, and just how Philips has been speaking to the Ghanaian government in infrastructure. Is that something that you intend to look at as you go through this roadshow on how you can partner with government in developing that infrastructure?
Yeah, I mean, a lot of the work that's going on with our local team here is also about rural health care and how do you get solutions that we can help to support that can really attack the problem from the ground up, you know, not waiting for the acute episode, but really provide solutions that allow clinicians out in the small clinics, out in the communities to make a difference early on in pregnancy, for example, and prevent some of the outcomes that occurred later during the pregnancy. So in that sense, yes.
Dr. Babela, I'd like to ask you, and you have extensive experience when it comes to working in both public and the private sector, having this kind of innovation that's coming from Philips right now, and having this, you know, when it comes to not only the research that they're doing, but also, you know, the clinical trial. How will this change, particularly here in South Africa, when we look at rural areas, for instance, if the midwife would be able to use this equipment? How could that change the face of how we're delivering healthcare?
Yes, I think there should be a continual search for a diversified range of establishment to come in, of establishments to come in and help this country to overcome some of its health delivery problems. And this diversified range of establishments I'm talking about could be from public sector, private non-profit, and private for-profit, just using the best that we can to try and provide the service to the needy population. As we stand now, the private health hospital sector is well positioned because it's the primary model of the private hospital is a multidisciplinary hospital. And we have hospitals in all the provinces in the country. And some of those provinces, the locations, in some of those provinces, the locations are quite close to rural hospitals. While we realize that the maternal health and child under 5 mortality are primarily preventable conditions. But when you look at the pipeline of the development of death from a preventable condition, you do get to a point where it gets to a need for curative care. And this is where we come in. And this is where this positioning and the geographical location that is favorable for us to be able to make a big impact on the South African health system. All that we really need to do is just to get the comfort amongst ourselves that we can work together to try and achieve this.
Professor Rees, I would like to ask you, we've discussed a number of things now. We've discussed a system, we've discussed equipment that could help. But at the end of the day, doesn't matter how amazing the equipment is, doesn't matter if we don't have a system that is conducive to be able to do what we would like to do. If you were to say what you would like to envision to be happening in South Africa right now, where we're probably falling short, what do you think it is?
So I think if we're saying that we want to tackle MDG 4 and 5, the first thing we would have to say is what are the sort of basic preventive things that we should be putting in place and covering adequately so that we start to prevent things. The other thing then is to get good curative services so that you have a rapid response. So I think in terms of maternal mortality, as I've mentioned, I think we really need to start looking very hard at how we reduce HIV in young women. We're still sitting in our antenatal clinics with about 30% of young women being infected with HIV, and that's still driving maternal mortality. And that's very complex because that can be anything from tackling gender-based violence, tackling gender relationships, to developing new products that women can use to protect themselves against HIV, to looking at behavior change amongst young women. So that is complex. But it's something that we've got to focus in the next 5 years very aggressively on. The other thing for women that we should be looking at is increasing access to contraception. Because one of the things we know in South Africa, although we are relatively better than other African countries, we've still got about 40% of women who are not choosing to become pregnant, who are not accessing any sort of effective contraceptive.
One of your concerns is that we had a measles outbreak not too long ago. What did that say to you about our level of efficiency when it comes to immunizations?
Well, similarly, the same you can say for preventing infant and child deaths. We want to say what are the preventive issues that we should really be looking at. And immunization is probably one of the most powerful public health measures that we've got. The fact is that in South Africa, and in fact throughout the African region, we've had a number of measles epidemics. And when you get measles epidemics, it's really a sign that your immunization system is failing, because measles is something that we give in the first year of life. It's an effective vaccine. And if we were doing that properly, we really shouldn't be seeing measles outbreaks. And the minute that you see them on the scale that we saw them recently, then you know that your immunization system has failed. And that is a threat. That's a real threat because vaccine-preventable diseases are still one of the commonest causes of hospitalization of children and of childhood deaths. So I think the first thing we have to say from both a community perspective and a health service perspective is we really should do the nuts and bolts of what we know works in terms of prevention as the first step. And then we have to look at some of these complex issues about how we're going to respond better when mothers in labor are needing obstetric intervention, when newborns are needing urgent intervention, because we are failing at both of those points as well.
I would like to bring you in. You were talking to me about some of the equipment that Philips is developing to tackle this particular issue.
Yeah, you know, we've been quite successful in the last 40 years, actually, since we've been involved in obstetrical and neonatal equipment. And one of the weaker areas, I would say, is having effective equipment at the right price point, because some of the geographies, some of the hospitals that we serve don't necessarily require, let's say, all the bells and whistles and the very fancy equipment. They're really basic quality equipment that does the job at an effective price point. So we've made a lot of investments these last years, and more are coming in the next couple of years, actually, where, for example, warmers and incubators, which are traditionally quite expensive pieces of equipment, and many children don't get access to that equipment just because they cannot be afforded in the particular hospitals. We're trying to bring out equipment that is very reliable, very solid, does the job, but at a very more affordable price point to get access to the technology that can make a difference. The same applies in obstetrics. You know, fetal monitoring, we've been in that industry for over 40 years, since 1968. And again, it's usually been quite, relatively speaking, expensive equipment. We have now got a range of products that is in a much more attractive price point that, again, does the job, monitors effectively, but we can get a lot more access to the equipment that would help during antenatal care than we would have in the past. Yeah.
Professor Fadeyeva, one of the things that you were saying to me earlier on is you were talking about that the whole issue of supporting a pregnant mom and where the funding of that would come from, or where we're going as South Africa. Would you like to speak to that?
I think the vulnerability of women in the sort of the antenatal period as well as the postnatal period is not actually recognized at the moment as an area for some form of coherent support. The impact or the cost of not intervening at that point is imperceptible within the economy, which is a problem, but it is actually dramatic, because the consequences of poor nutrition in the antenatal period is problematic, and there is lots of evidence that a substantial number of women, probably up to about 50%, facing severe difficulties during that period. It becomes a life crisis having a child, and most of the pregnancies are unplanned. A lot of people can't leave education, and a lot of people leave employment, and a lot of people have their employment prospects because they have children permanently affected, and their ability to look after children after they get born is also affected with a big intergenerational impact. So there has to be some coherent way, as many other countries, the entire Latin America have programs that address this particular period. And they provide income support to people during that period. They provide that income support to assist them with transport, which is about 25% of their costs during that, and about 65% is housing, and the rest is food. If you provide people with income support, they will supplement it with those which they are currently having a shortage of.
What I'd like to ask you about that, one of the discussions that we've had, and we have this probably every year when we talk about when we have the budget speech of social grants. And you know, with the tax burden and people saying that when it comes to social grants and how much money is going into that, taxpayers already feel heavily burdened. Would this be money, when you're talking about this support, would this be money coming from the current budget, or would you be looking at another grant?
Well, I think, firstly, social grant expenditure is about 3.4% of GDP. And the moment you fix the grants, most of the grants only increase with inflation, which means that the moment you've upscaled a particular program, it actually declines as a percentage of GDP systematically over time. So it doesn't provide a shock. Mostly what social grants do is they're a consumption smoothing exercise. We've got very, very skewed distributions of income in South Africa, and these compensate for that skewness in the distribution of direct income. So if in many other countries their natural income distribution is fairer than South Africa's, so technically you have better spend across all income categories. So this is not a tax burden on high-income people. This is basically a more appropriate spreading of consumption, and particularly around these vulnerable groups, because the false economy of not supporting women at that stage is poor development of children, which is lower education results, lower social integration of those children at future, and the mothers, the younger mothers, their social integration in the country is also affected on a mass scale, because this is a problem that will affect probably up to about 60% of women. So the issue of how you look at that is important. Also think that a lot of the comments that are generally made are very uninformed about the social grant framework. People talk about 15 million grants. Most of them are for 10 million children. They're not meant to be employed, and it's not really a burden on the taxpayer. So health expenditure is higher than social grant expenditure in South Africa in the public sector. And just incidentally also to just correct a comment on the distribution of workforce between the public and private sectors. The numbers that were quoted earlier are in fact related to the percentage of the total number against total registered doctors, not actual people working in South Africa. And in fact the distribution is roughly 65% of medical personnel work in the public sector. So our healthcare resources are quite well addressed, but they're not necessarily working very well. And in terms of the income support for women, we have long-term hidden implications of not providing adequate support during this period.
Thank you so much. Well, what we're going to do now is we're going to take a short break, and then when we return, we'll continue with this discussion.